with the infectious disease of lung and infectious disease. So let's start with the case scenario. Mm. Mm. It's a 25 years old male presented with history of cough with sputum production for 3 days and fever for 3 days with a history of breathlessness for 3 days and breathlessness for 2 days. With on examination, the respiratory rate is super high. Admit got the for 2 days, and on examination the respiratory rate is 25 per minute and pulse is 110 per minute, so it's tachycardic. Tachycardia was there, and then there is a decreased movement on the left side on examination of the chest, and trachea is central. Trachea is centrally placed, and the buccal fremitus, when you are going to examine, the asking 1 2 3 1 2 3 and comparing the both side, it is increased on the left side. So buccal fremitus, and there is a dullness on the left infrascapular area is there on the same area. And then the vocal resonance, when you ask the patient to say 1 2 3 1 2 3, and by auscultation you are finding the increased sound which is you are hearing from the earpiece, so that's a increased vocal resonance. And on the breath sound you are going to find the bronchial breath sound. So this is the finding of the patient that will mainly presented with the patient with classical case of pneumonia. Okay, so this is the CVS and per abdomen is normal findings. So this is the case. So we are going to discuss with the community acquired pneumonia. So we are going to classify, so what are the types of pneumonia, what's the definition of pneumonia, and going through the etiology and then the investigations and then the treatment regimen for the pneumonia. So as a classification, it is classified as a community-acquired pneumonia. Another is healthcare-associated pneumonia, hospital-acquired pneumonia, and ICU-associated pneumonia, and then the ventilator-acquired pneumonia. So all these healthcare-associated pneumonia, hospital-acquired pneumonia, ICU-acquired pneumonia, and ventilator-associated pneumonia, all these comes into a nosocomial pneumonias. Okay, so these are the nosocomial pneumonias. So coming to the definition of the community-acquired pneumonia. So the community-acquired pneumonia is defined as an acute infection of the pulmonary parenchyma, parenchyma that is associated with some symptoms of acute infection accompanied by the presence of an acute infiltrate. So there should be an acute infiltrate on a chest radiograph or auscultatory findings consistent with pneumonia. So that's, you are going to find the bronchial breath sound, or you are going to find out the crepitation in a patient not hospitalized or residing in a long-term care facility for more than 14 days before the onset of symptoms. So this is the presentation the patient of community-acquired pneumonia. So patient should not be hospitalized. Patient should coming from the community and not hospitalized more than 14 period of 14 days before the onset of symptoms to say this as a community-acquired pneumonia. So community-acquired pneumonia has signs and symptoms of acute infection with acute infiltrates on the chest X-ray. So you can find the microscopic, the inflammatory cells and all these things. Pathological specimen showing consolidation. So there's a red hepatization is there, and then on the X-ray you can find the opacity. Okay, so this is the opacity that you are going to find in the classical community-acquired pneumonia. So what is the epidemiology? So the important cause, it is one of the important cause of the death from the infectious disease. 20% require hospitalization and 10% needs ICU care, and increase in extremes of ages. So it's increase in the extremes of ages, and 10% needs ICU care. Number is rising in elderly more than 65 years. So most of the older patients are more common for the community-acquired pneumonia. And then the low outpatient mortality is 1 to 5% with the patient representing the OPDs, and then high mortality in the hospital and ICU. So most of the hospital mortality and ICU which we are going to get is because of the mainly of the pneumonia. Okay, so this hospital mortality and ICU mortality is more common on this. So what are the host risk factors for the infection? As you know, so for that advanced age, defective phagocytosis, defective immune dysfunction, alcoholism, poor nutrition, smoking, comorbidities, and if the patient is on installation or hospitalized, so then that's the has a high risk of infection on this group of patient. So the pneumonia also plays on this part. And then what are the pathogens in community-acquired pneumonia? So community-acquired pneumonia, the pathogens most commonly is a Staphylococcus pneumoniae. So it can be a penicillin sensitive or penicillin resistant. The another is a Haemophilus influenzae. So it's ampicillin sensitive as influenza or ampicillin resistant as influenza. Moraxella catarrhalis, all strains penicillin resistant is mainly a Moraxella catarrhalis, and atypical pathogens like mycoplasma pneumoniae, chlamydia, and Legionella. So these are the atypical organisms that is mainly responsible. So most common is strep, followed by H. influenzae, and the Moraxella catarrhalis, and atypical is mycoplasma pneumoniae, chlamydia, and Legionella. The other pathogens, which is more common, is Klebsiella pneumoniae in the chronic alcoholic patient. Staph aureus, it is complicates the influenza or any viral infection. Okay, so if the patient is having a viral infection or influenza or flu, and the patient presented with a pneumonia, then we have to think about the Staph aureus. And then the Pseudomonas aeruginosa in the case of bronchiectasis and cystic fibrosis. And anaerobic organisms are mainly when there is a high chance of aspiration pneumonia. So if there is a aspiration, or if the patient is vomiting and there is aspiration, regurgitation, and all these things, then we have to think about the anaerobic organisms is the culprit in the formation of pneumonia. And the another is a histoplasmosis, coccidioidomycosis, and blastomycosis. It has such a specific geographical distribution. In that case, you have to think about this fungus. So histoplasmosis, coccidioidomycosis, and blastomycosis. 70 to 28% of the community-acquired pneumonia is because of a mycoplasma pneumonia in the older and adults. Legionella is an exposure if the patient has exposure to the cooling towers, like if the patient is more working on the AC vents, if the patient is traveling on the cruise ship. So then the Legionella is more common, and then the Chlamydia psittaci is mainly common in the bird handlers. Okay, so these are the most common organisms. So, and also we have to think about the community-acquired pneumonia by site of the care. Okay, site of the care, outpatients, most common is Staphylococcus pneumoniae, so mycoplasma pneumoniae, H. influenzae, chlamydia pneumoniae, respiratory viruses is more common in the outpatient. So if the patient is hospitalized in non-ICU, it's mainly a strep pneumoniae, mycoplasma pneumoniae, chlamydia, H. influenzae, and Legionella. And the respiratory viruses. While in the ICU settings, the most common is a strep pneumoniae, Staphylococcus aureus, Legionella species, gram-negative bacilli, S. influenza, and respiratory viruses. So that's why empirically, if we are choosing the antibiotics, so we have to cover up the gram-negative in this group, and also we have to cover up the Staph aureus and the atypical organisms. Okay, to think about. Okay, to cover up all these organisms while treating the organism empirically. So coming to the pathophysiology, so community-acquired pneumonia usually is acquired by the inhalation or aspiration of the pulmonary pathogenic organisms into the lung segment or lobe, and less commonly community-acquired pneumonia may result from the secondary bacteremia from the distant source such as E. coli, urinary tract infection, and or bacteremia. Community-acquired pneumonia due to aspiration of the oropharyngeal contents is the only form of community-acquired pneumonia with multiple pathogens. Okay, so this is the mainly the community-acquired pneumonia because of the aspiration. You can find the multiple pathogens. So what is the clinical feature manifestation? So clinical manifestation of the patient who presented with community echo pneumonia, you can get the fever. Patient will have chills. There's a pleuritic chest pain. Patient will complain of cough, which is liquid, purulent, and all the classical is rusty. Okay, and bloody sputum might be there, and patient will have a dyspnea. And then on the examination, you can find the findings of consolidation as I described in the 20%. Okay, so there's the increased vocal fremitus, increased vocal resonance, dullness, and then the bronchial breath sound. So it is the typical finding is only after 20%. Otherwise, you can find the other findings like crepitation, all the things. And pleural rub is in 10%. And the another is a fatigue, headache, myalgia, arthralgia will be there, nausea, vomiting are the other features that you can have, diarrhea. So these most of these nausea, vomiting, diarrhea, GI symptoms you are going to get in the case of atypical pneumonias. And the patient will have a confusion. There will be a tachypnea, so respiratory is going to be increased. There will be a tachycardia, and there will be a hypothermia and jaundice. Okay, so jaundice will be there. Can be also be there if the patient has a atypical pneumonia like Legionella pneumonia. You can get the jaundice. Okay, so it's in the type of Legionella pneumonia that is known as a Legionnaire's disease. Okay, and then coming to the two types, classically you can divide into community pneumonia in the classical community pneumonia and atypical pneumonia. Okay, so that is classical is typical and atypical. Okay, so two type of presentation. So classical, the patient will have a sudden onset of community acquired pneumonia. The patient will have a high fever, second chills will be there, pleuritic chest pain, shortness of breath, pleuritic cough, rusty sputum, the blood tinged sputum will be there. The patient have a poor general condition, and there is a high chance of mortality up to 20% in the patient who is have a bacteremia. Okay, and then the strep pneumonia is a mostly common causative organism. While in the atypical, this is also known as a walking cap. Okay, so patient is coming normally walking to the OPDs. A patient will have gradual and insidious onset. Patient will have low grade fever. There will be a more common is a dry cough. There's no blood tinge, and the patient is having a good general condition. So that's why it's known as a walking cap. Then the low mortality of 1 to 2%, except in the cases of legionellosis. Okay, so a legionella disease because it has a high mortality if you are not going to diagnose immediately. Okay, so, and the mycoplasma, chlamydia, legionella, rickettsia. So now lot of patient with scrub typhus we are getting with a pneumonia. Okay, so the lot of patient. Okay, so if the pneumonia is there, high grade fever. So if it is negative, COVID negative in the present situation, then we have to send for the scrub typhus, and we are getting a lot of patients with the scrub typhus. Okay, so that's a rickettsial fever. And then the viruses are the mainly a causative organism. So that's the atypical one that we have to think about. Etiological diagnosis of community acquired pneumonia, the history, physical examination, and chest X-ray. You can go for the sputum gram stain culture in the culture of the sputum and blood, and you can send for the serology. Special studies in the selected patient and invasive procedures can be done to prove the etiological diagnosis. Okay, so etiological diagnosis. So what is the imaging that you can do is a chest X-ray. So radiological diagnosis. So in the chest X-ray, you can find the only one lower opacity that is more common on the in the situation of Streptococcus pneumoniae, Klebsiella, H. influenzae. H. influenzae, Staph aureus, and Mycobacterium tuberculosis we can find the lower opacity, and only the focal opacities. Okay, in the X-rays and in the CT scan, the focal opacity. Then we can think about strep pneumonia, Mycoplasma pneumoniae, Legionella, and then the Staph aureus and the chlamydia. If the patient has an interstitial pattern, okay, so interstitial pneumonia like pattern is there, so only the interstitium is involved, then we can think about the viral pneumonias, so like any rhinovirus or adenovirus or respiratory syncytial virus, any influenza A and B, and then also in the case of COVID. Okay, so COVID and the Mycoplasma pneumoniae, chlamydia, psittaci, you have to think about the interstitial. And if you are finding cavitations, okay, so cavity is there, so cavity is there, so these are the cavities. And if the cavity is there, then we have to think about the mixed aerobic and anaerobic gram-negative bacilli, Pneumocystis carinii, and Mycobacterium tuberculosis. So Mycobacterium tuberculosis is more common in our case, so if there is a cavitation. Then coming to the another one is miliary. So miliary is miliary modeling is like a small millet-like seeds, like opacities that you can this dot pictures in the whole chest, so that you can think about. So the differential diagnosis of miliary is miliary tuberculosis. The another is histoplasmosis, and then the varicella zoster. Also, you can find the miliary modeling. And then the another is bulging fissure. So what is bulging fissure? That is so this is the bulging fissure. So this is the fissure. Okay, so this is the horizontal fissure which has been bulged, and this is the opacity, and this is the lateral X-ray that you can see the bulging of this fissure. So it is mainly common in the Klebsiella pneumoniae, so also known as a right upper lobe Flanlanders pneumonia. Okay, so these are the things that you have to think about. And then the interstitial infiltration with lymph nodes, then the mycobacterial pneumonia, Chlamydia psittaci, Epstein-Barr virus, nematocysts is Staph aureus, and another is a Pneumocystis carinii. Okay, so there's the nematocysts. So you can find the nematocysts on this conditions. So serological diagnosis is a limited value antibody rise occurs 2 to 4 weeks after the onset of symptoms. A single titer can be helpful in the diagnosis of Mycoplasma pneumoniae, Chlamydia, Legionella, and Coxiella burnetii. Okay, so these are the single titer can be helpful if you are going to do the antibody titers on in this group of patient. So what is a new diagnostic test that you are going to do is a immunochromatographic ICT urinary antigen test, nucleic acid amplification test like PCR, and the procalcitonin is a more rapid etiological diagnosis that you can going to do. Then coming to the urinary antigen test, much less influenced by the prior antibiotic therapy and fast test that you can do. So in case of pneumococcal urinary antigen and Legionella urinary antigen, that you can going to do the urinary antigen test to diagnose the Legionella and pneumococcal pneumonia. So this in pneumococcal pneumonia, when the cultures cannot be obtained in a timely fashion, then you can do the urinary test. And then the disadvantage is cost and lack of organism isolated phosphorus test. And the positive test results are obtained for several weeks to months after recovery. And the nasopharyngeal carriers of Staph pneumoniae can cause the false positive results. So ideally, so for the pneumococcus, the culture is more useful. So while in the Legionella can detect only one species, Legionella pneumonia, and only one subgroup, and with a sensitivity of 70% with a specificity of 90%. So urine is positive for antigen on day 1 and continues to be positive for the week. So that's why Legionella, for the Legionella, you can go for urinary antigen test. And now the PCR, so for any viral infection or anything, so you can go for the PCR. Okay, so in the case also in the COVID pneumonias and the influenza A and B, you can go for the PCR and nucleic acid amplification test. It has a greater sensitivity, possibility to identify drug resistance also, and less affected by the prior antibiotic therapy. And so these are the things that you are going to do. Real-time PCR is a better method, so which we are going to use for any viral infections nowadays with a real-time PCR. So Staphylococcus pneumoniae easily detected by PCR also. So and chlamydia, mycoplasma, and other respiratory viruses are difficult to culture. So, but you can do with a real-time PCR that we can find it rapidly. So another is biomarkers that can be used is a procalcitonin. It distinguishes between bacterial and non-bacterial causes. So it's a procalcitonin is a peptide precursor of calcitonin. So so it is produced in the response to the bacterial toxin and certain bacterial specific pro-inflammatory mediators like interleukin 16, anti-TNF alpha, and interleukin 6. Okay, so these are the biomarkers that can be used to see whether it's a viral or whether it's a bacterial. Okay, so if the procalcitonin is raised, then we can think that is we are dealing with a bacterial pneumonia. So then we can use the antibiotics on that. And then the another test you can do is the invasive test, that is a fiber optic bronchoscopy in a diagnosis of communicable pneumonia. So it's a progressive and non-resolving clinical course. In that case, you can use the fiber optic bronchoscopy, differential diagnosis with non-infective pathology, suspicion of non-bacterial or opportunity infection, and the BAL quantitative culture that you can use. Okay, so it is mainly in case of fiber optic bronchoscopy. In that condition, you can use the fiber optic bronchoscopy invasive test. And then for the sputum examination, the findings suggest of pulmonary infection, direct examination you can do is the sputum stain. So if the squamous cell is more, then the sample is not adequate. So then we have to repeat it. Okay, so for the gram stain, and then the culture. The another one is a sputum culture that you can do is the only 40% of the sputum culture identify a pathogen. So blood culture is helpful in 15% only, and serology establish the diagnosis in 25% of the patient. So for the etiological diagnosis, definitive blood culture positive for the pathogen, pleural fluid positive for the pathogen, a fourfold rise in the antibody titer of Mycoplasma pneumonia or chlamydia pneumonia should be there, and positive urinary antigen, positive direct fluorescent antibody test for Legionella if it is present, serum or urinary positive for strep pneumonia antigen, and microenvironment in the sputum. So there's a definitive pathogen that we have diagnosed, and there's a etiological diagnosis can be made. Probable, when you say the probable cause of pneumonia is a heavy or moderate growth of predominant bacteria on the sputum culture and compatible gram stain. And sputum gram stain is more than 25 polymorphonuclear cells per low power field and less than 10 squamous epithelial cells, and the aspiration pneumonia on the clinical grounds. Okay, so aspiration pneumonia clinical, then is we can say is a probable one. So coming to the flow chart, how we are going to evaluate the patient with common trachea pneumonia. First, you take the history, physical examination, and chest X-ray. So no infiltrate, then we have to think about the alternate diagnosis. If there is an infiltrate or clinical evidence of common trachea pneumonia, evaluate the need for the admission. So what how to evaluate? So use the two scores, that's CORP 65 and port score. Okay, so CORP 65, which we are going to use is very easier one. So this is given in your textbook, Davidson also. So according to that, you can use the treat the patient as the outpatient, medical ward, or ICU admission. So what is the factors increasing the mortality in common trachea pneumonia? So patient, if the patient has a historical data of serious comorbidity, patient is on immunosuppressant, inadequate or delayed antibiotic therapy, respiratory failure, mechanical ventilation, recent hospitalization, and atypical clinical presentation as age more than 65. So there is a high factors of increasing the mortality in the patient with common trachea pneumonia. And if the patient is having this, it's better to admit the patient and start the treatment immediately. And the vital signs, so the respiratory rate is more than 30, tachycardia is there, and systolic and diastolic hypotension is there. If the systolic blood pressure is less than 90 and diastolic less than 60, then you have to be more vigilant, and fever more than 38 degree, and patient is febrile also. So these are the factors increasing the mortality. And lab findings, if the burn pearl urinary is more than 20, if the patient has a leukocytosis and the patient has a leukopenia, if there is a multilobar infiltrates, patient has a rapidly progressive infiltrates during therapy, if the patient has a bacteremia, if the patient has a hyponatremia less than 130 millimole per liter, if the patient has a multi-system organic dysfunction, and type 3 pneumococcus, Staph aureus, gram-negative bacilli, and the aspiration. So these are the factors which increase the mortality in the patient with a pneumonia. Other high risk presentation, patient may have a neutropenia, patient will have a decreased platelet counts, thrombocytopenia, metabolic acidosis, patient might be have a hypothermia, hypoglycemia, acute alcohol ingestion, delirium, tremors, and the history of family history. All these are the other risk of the presentation. So I'm not going to go for the port screening because there is a lot of things that we are going to use on this. So it is a cumbersome thing that port we are not going to use. So we are going to use the CORP 65. So in the CORP 65, so what is C? C is a confusion. U is a urea. So urea more than 7 millimole or blood urea nitrogen of more than 30. Respiratory rate, R is respiratory rate more than 30, and blood pressure of systolic blood pressure less than 90, and diastolic blood pressure less than 60, and is more than 65. For each, you will give the 1 point if it is present. Okay, so if the curve is 0 to 1, you treat the patient at the home. If the curve 2, you will sort hospitalization will be advised, and curve 3, the patient should be treated in the medical ward, and the patient has a curve 4 or curve 5. Okay, so the points, then you can transfer the patient for the ICU care. So this is how you are judging for the admission of the patient with the community acquired pneumonia. So this is very important. So CORP 65 you should know. Okay, so what is C, what is U, what is R, what is B, and what is 65. Okay, so CORP 65 rule for the management of community acquired pneumonia. So what is the empirical antimicrobial treatment that you are going to use? Should include the treatment for the strep pneumoniae, gram-negative bacilli, staph aureus, and the streptococci, and the atypical pathogens. Okay, so this is the empirical. So we should cover with strep pneumonia and gram-negative also, and then staph aureus, and then the atypical pathogens. So that's the empirical treatment. Okay, so that's the empirical treatment that you are going to. So the therapy, mainly we have to avoid the emergence of the multi-drug resistance or to the organisms. So that's mainly first objective that we should have. And the secondary is the immediate treatment of the patient with a serious sepsis. Okay, so that's the mainly a therapy of to be considered. So what is the empirical treatment? So this is the American Thoracic Society and Infectious Disease Society of America guideline for the treatment of the community acquired pneumonia. So it's the empiric treatment you are going to, so this is given in your Harrison. Okay, so in your Davidson you are going to read about the BTS. Okay, so British Thoracic Society, but we are using the ATS and IDSA. Okay, so IDSA guidelines for the treatment of pneumonia. So in the empiric treatment, the outpatient is mainly healthy and no risk factors of drug resistant streptococcus pneumonia. You will use the macrolide like azithromycin. Okay, so azithromycin, or you can use the doxycycline 100 milligram BD or azithromycin 500 milligram OD for 5 days. Okay, so that's the mainly thing that you are going to use. And then the presence of the comorbidities, use of antimicrobials within the previous 3 days. Okay, so if the patient has 3 months, sorry. So presence of comorbidities is there, and use of if there is a history of use of antimicrobials within the previous 3 months, then you have to choose the different groups. Okay, on that. So if the patient is not taking any beta lactams, then you can choose the respiratory fluoroquinolones. If the patient has taken the beta lactams, has taken the fluoroquinolones, then you can change into beta lactams. Okay, so that's how you are going to change on that. So in that you can use whether respiratory fluoroquinolones like levofloxacin, gemcitabine, or moxifloxacin, or you can use the high dose amoxiclavulinic acid combination, or you can use the ceftriaxone, cefuroxime, plus you can add the macrolide, that is azithromycin, or you can use the doxycycline. So that's the one regimen that you are going to use. Okay, so in this, if the patient is going to be admitted. And then in the patient with the empiric treatment, so inpatient, if the patient in non-ICU, then you are going to use the fluoroquinolones, levofloxacin, gemcitabine, or moxifloxacin, or you can use the cefotaxime, ceftriaxone, amoxiclavulinic injectable, and then the macrolide. And if the patient is penicillin allergic, then you can use the first respiratory fluoroquinolones or ertapenem. Okay, so ertapenem is the another option that you can going to use. Okay, so these are the inpatient non-ICU patient. If the patient is inpatient in ICU, then you are using this combination: cefotaxime, ceftriaxone, ampicillin, sulbactam, plus azithromycin or fluoroquinolones. Okay, so 2 drugs that you can use, either azithromycin or fluoroquinolones plus cefotaxime, ceftriaxone, or ampicillin, sulbactam. Or for penicillin, you can use the respiratory fluoroquinolones and carbapenem, that is known as the ertapenem, known as azithromycin. So this is the ideally regimen in patient in ICU. Or if we are going to suspect the pseudomonas, just like in our bronchiectasis cases. Okay, so if the patient is on the bronchiectasis, the patient has a history of previous hospitalization and all these things, then you can use the piperacillin, tazobactam, cefepime, carbapenem, and then the plus cipro or levo. Okay, so that's the another thing that you can use. And above beta-lactam plus aminoglycoside plus azithromycin that you are going to use. And above beta-lactam plus aminoglycoside plus an anti-pseudomonal or anti-pneumococcal fluoroquinolones that you are going to use. Okay, so that's mainly in the plant. If penicillin allergic, aztreonam for the beta-lactam. So that's the another option. And so we have to consider sometimes the methicillin resistant tuberculosis, pneumonia. So when to suspect? So if the multi-drug resistance, gram negative to suspect, and MRSA, if the patient has a history of hospitalization more than 2 days in previous 90 days, use of antibiotics in previous 90 days, immunosuppression is there, patient has a non-ambulatory status, tube feedings, gastric acid suppression, severe COPD or bronchiectasis, nosocomial MRSA, hospitalization more than 2 days in previous 90 days, use of antibiotics in previous 90 days, chronic hemodialysis in previous 30 days, and the documentation prior to MRSA colonization. So all these are the risk factor for the methicillin resistance Staph aureus. Okay, so in the community acquired Staph aureus, when you have to suspect if the patient has a cavity infiltrate or necrosis, patient has a gross hemoptysis, neutropenia, erythematous rash, concurrent influenza, young, previously healthy status, and summer month onset, then we have to think about the patient with a community acquired MRSA. Then empirical treatment for community-acquired methicillin-resistant Staph aureus, vancomycin or linezolid, neither is an optimal drug of MS methicillin-sensitive Staph aureus. For methicillin-sensitive Staph aureus, beta-lactam and sometimes respiratory fluoroquinolones until necessary results you can use, and specific therapy with a penicillin, resistant sympathetic penicillin or cephalosporin that we can consider. Okay, So these are the doses that you can use for the treatment. So doxy 100 to 200 milligram, azithro 500 milligram OD, and then the levofloxacin 750 milligram, and moxifloxacin 400 milligram IV or per OD for 5 to 7 days, amoxicillin 2 gram amoxi plus 125 milligram clavulanic acid BD for 7 to 10 days, or amoxicillin 500 milligram plus 125 clavulanic acid thrice daily, or ceftriaxone 2 gram IV BD, or you can use on that. So this is the doses that you can use. So then you have to look for the response to the treatment. So what is the adequate response? So if the patient has a clinical improvement within 48 to 72 hours according to ATS or European Respiratory Society guidelines, and subjective response within 1 to 2 days or 3 to 5 days. Okay, so it's mainly fever. Fever usually persists for longer than other signs and the symptoms. Okay, so this is the how you are going to say whether the patient has adequate response or not. Clinical resolution can be delayed according to the age, if the patient has a comorbidity, severe infection, and other host factors. So radiographic deterioration is common during the first several days of the treatment, reflecting continued inflammatory changes in the absence of the viable bacteria. So that's going on. So that's why you shouldn't be worried about the deterioration of the chest X-ray. Okay, so chest X-ray on that. So this is the response to the treatment. So what is the criteria for the ICU admission? So already I told you, so it should be curve 3. So I'm not skipping this. So coming to the management of the poor responders, so consider non-infectious illness, consider less common pathogens, consider serological testing, and broaden the antibiotic therapy if the patient is not responding. And then we have to also consider for the bronchoscopy also in the case of patient with non-responder. So what are the complications of the community-acquired pneumonia? So community-acquired pneumonia, the complication, the patient can land into hypotension and septic shock. So there can be a associated pleural effusion that is known as a synpneumonic or parapneumonic effusion in 3 to 5%. There can be a clear fluid, or you can also get the pus. So that is the empyema. So 1% of empyema thoracic pus in the pleural space you can going to find. You can have a lung abscess and destruction of the lung. Okay, so chronic structural lung disease. So that's mainly the ultimate thing that is going to happen. And then the aspiration anaerobes, pseudomonas, and then the multiple metastatic metastatic disease, that is in case of Staph aureus. Patient can have a septicemia leading to brain abscess, liver abscess, and patient can have multiple pyloric abscess, and ultimately the most dangerous one is acute respiratory distress syndrome. Okay, so ARDS, the patient will have ultimately expire because of the patient will having ARDS. So viruses So pneumonia in the normal host, adults and children, influenza and B, respiratory syncytial virus and parainfluenza. Pneumonia in immunocompromised, mainly in case of measles, HSP, CMV, HSO, and influenza viruses, can cause primary viral pneumonia, cause partial paralysis of mucociliary escalators, so increased risks of secondary bacterial lower respiratory tract infection. Staph aureus pneumonia is a known complication following the influenza infection. Okay, so this mainly we have to think about the viruses, and then the other is mainly a notorious organism is a fungal in case of immunocompromised patient, if the patient is having a pneumonia. So how to do best to win the war is to early antibiotic administration with 4 to 6 hours, empiric antibiotic treatment as per guidelines. Okay, so that's mainly a treatment goal. And you are going to use the port or PSI scoring, or you can use the CORP 65 is mainly the thing that you are mainly using. So you are not going to use the port. So we are using the CORP 65. CORP 65 for 3 and 4 required ICU care, and change antibiotics as per pathogen and sensitivity pattern. That's mainly thing. And decrease smoking cessation. Smoking cessation is the mainly advisable, and advise counseling on that. And then the arterial oxygenation and assessment in the first 24 hours is the mainly, and the blood culture collection in the first 24 hours prior to the antibiotic treatment. And pneumococcal and influenza vaccination, and always smoking cessation should be advised for the patient for the prevention. Okay, so this is the how you are going to treat the patient with the pneumonia. Okay, so this is the how I'm going to conclude this the of the community acquired pneumonia slide. Now on the next we are going to start with the hospital acquired pneumonia. Time सकिनलाई rejoin गर है. So then the reasons of treatment failure. So is mainly the thing is the incorrect diagnosis and correct care diagnosis. Incorrect, then it can be you have to think about the congestive heart failure, embolus, neoplasm, sarcoid. Okay, so all these are the other things that you have to consider. Correct diagnosis, you have to think about the local factors, obstruction, complications can be there, empyema, and the drug might be error in drug selection, error in a dose might be there, and the pathogens you are treating with the drug resistance organisms with the drug which is not working on that. So we have to think about this if the patient is not